Hi guys, welcome back. So hope I am live and audible to all of you. So I'm Dr. Patil, and in next 30 minutes we will learn some essential skills useful for the NEET PG exam. We will call it as the. Okay, just give me a second. Can you confirm if I'm audible to all of you? Okay. Hmm. Okay, am I audible now? Okay, good. So we'll spend 30 minutes learning about how to pick up clinically oriented MCQs, because all of us know that nowadays plenty of questions are clinically oriented. You may know everything about the disease, and you may be able to answer the question, but if you don't know that this whole story is talking about this particular disease, you may not be able to diagnose. Like for example, there may be a story where patient presented with some weakness and respiratory difficulty and he was put on ventilator, and they mentioned that on examination there were a group of muscles showing flaccidity and there were a group of muscles showing the spasticity. This is a story. Now, until and unless I can make some diagnosis out of this story, anything they ask about this patient or this story, I will not be able to answer. They're asking what would be the most common cause of death in this patient. But I don't know what this question is talking about, then I may not be able to answer. Why am I not able to answer? Why am I not able to decipher from the story? Because I've read this story is actually of a patient, let us say, with amyotrophic lateral sclerosis. So I might have read about the ALS, but then I don't know how to pick up that this question is talking about ALS. So in the story that I told, there were sufficient masala to diagnose it as ALS. What was the masala? The main masala was that this patient had flaccidity, which is a sign of element damage, and this patient also had spasticity in some group of muscles, which is a sign of UMN damage. And any question that examiner is throwing at you where patient has findings of both UMN and LMN, there are other causes, but for the exam it should always go in favor of ALS. So this is the clue. Any question which talks about LMN damage findings plus UMN damage findings in a single patient, for all practical purpose in the NEET PG, INI-CET, FMGE exam is talking about ALS. So once I know this clue, now I know this question is talking about ALS. But most of us don't pick these clues during our study. We just focus on cramming the facts, epidemiology and other stuff. Only few things we pick up during our MBBS. It's like malar rash. Any question that talks about malar rash is talking about SLE. But similarly, there are a lot of telltale clues that we should learn to pick. So how do I get to know that this question is talking about a particular disease? We will call them as clinical clues, and there are 4 areas where the clues will be distributed. The first one is demographics. So every time you study about a disease, please think about it. Whether this is a disease of young individuals, whether this is a disease of the middle-aged adults, or whether it is a disease of elderly. For example, if I say SLE, what do you think? SLE is a disease of middle-aged. Disease of middle-aged, right? On the other hand, if I say Parkinson's disease is the disease of elderly. So once I have this in mind, I wouldn't think of Parkinson's disease if a question is talking about a 20-year-old patient, right? Similarly, I wouldn't think of SLE if the question is talking about an 80-year-old male, right? Similarly, SLE is primarily a disease of females. Parkinson's disease is a disease more common in males than females. So these demographics hold some clue, need not be very important in many questions. Second is the history pointers. This is the most important part when it comes to dealing with the clinically oriented MCQs. Examiners are so kind, they always give you clues for the diagnosis, right? I will write a clue, you tell me which disease this question is talking about. I think all of you are able to pick this up. If the question talks about worst headache ever, worst headache ever, what is this talking about? I think all of us know any question which talks about worst headache ever, examiner is directly telling you that think about subarachnoid hemorrhage. Think about subarachnoid hemorrhage. So whatever question clinically oriented you're dealing with, first concentrate on the demographics. You may be able to rule out or rule in many options. After that, think about the key statements made by the examiner. If he says worst ever headache, it is subarachnoid hemorrhage, right? If the question says this patient has got headache which is highly sensitive to indomethacin, then it is talking about paroxysmal hemicrania. So similarly, there may be statements which are telltale clues. So every time you study about a disease, highlight those statements. Like if this statement appears, the examiner is talking about this question or this disease, and I will always think about it, right? Then third, there may be some important signs mentioned in the question. Like if that sign is present, the question is mostly talking about that particular disease. For example, if there is, let us say, malar rash present, then we know it is talking about SLE. Right. Then last one is some crucial investigations will be mentioned. For example, let us say the question is talking about Dawson's fingers. What Dawson's fingers point towards? If the question is talking about Dawson's fingers, it is pointing towards multiple sclerosis. So every clinically oriented question, try to find out a clue under these 4 categories. Either demography may hold the clue, gender, age group. Second, there may be clear statements in the history by the examiners which are directly telling you that this question is about a particular disease, or presence of some important signs, or presence of some important investigation findings. So what we will do today is we will go through some 2-3 systems. We will list the important diseases and what are the clues that examiners give for you to make the diagnosis of those diseases in clinically oriented questions. So let us start first with the cardiology. So when I'm talking about cardiology, one of the question can come from acute pericarditis. So how will I get to know that the patient is, in the question is talking about acute pericarditis? The patient of acute pericarditis will have chest pain. So it will mention chest pain, which is, the clue point here is the chest pain which is worse on inspiration, So if I have ischemic heart disease or angina, the chest pain is not going to be worse on inspiration. So the chest pain worse on inspiration is a possible pointer towards acute pericarditis. Another is pleuritis. That is first point. Again, the second point that the question may be talking about, this was a history pointer. Then investigation pointer, like history, another important point. This will be worse on lying down or supine position. And in terms of investigation, they may mention ECG. The clue on the ECG is, in case of MI, we know that there should be ST elevation and reciprocal ST depression. Here also there may be ST elevation, but the main clue is PR segment depression. So if the question talks about chest pain with ST elevation, it is talking about STEMI. But if the question talks about chest pain with ST elevation, along with that there is PR segment depression, it is talking about acute pericarditis. So this is going to be your clue on the ECG, PR depression and chest pain which is worse on inspiration. Similarly, if there is a question on heart failure, what is it going to talk about? Of course, we all know about the heart failure. If it is a right heart failure, the question is going to talk about raised JVP, ascites and edema and hepatomegaly, right? And hepatomegaly. On the other hand, if it is left heart failure, if the question is talking about a patient with left-sided heart failure, it will talk about PND and orthopnea. These are clinical clues or history clues. And what will be the lab clue? Like we had PR segment depression for the ECG. The lab clue for the heart failure will be raised N-terminal pro-BNP. So any question which is talking about raised N-terminal pro-BNP for the NEET PG exam is practically talking about heart failure, right? Now, similarly, there may be a question on dilated cardiomyopathy. So if the question is talking about dilated cardiomyopathy, how will I get to know? What will be the clues? The first clue, alcohol. The most common cause for dilated cardiomyopathy is alcohol. So they may mention that there is history of alcohol dependence or long-standing alcohol consumption. Second, they may mention that the left ventricular end diastolic diameter is more than 6 centimeter. The third thing the question may be talking about is cardiomegaly, because when there is dilatation of the heart or left ventricle, the heart appears large. So there may be cardiomegaly. Third, the question may also be mentioning of features of heart failure. Features of heart failure. So if the question opens with a person who is alcohol dependent and he has presented with heart failure, X-ray shows cardiomegaly or echo shows left ventricular end diastolic diameter more than 6 centimeter, it is talking about dilated cardiomyopathy. Now, similarly, there may be a clinically oriented question on what we call as hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy. So how will I get to know that the story is of this patient? If the question is about hypertrophic cardiomyopathy, it will be talking about an young patient, right? Young individual. It may be talking about recurrent attacks of syncope or arrhythmias like VT or VF. The story goes like this. An young patient presented with recurrent attacks of loss of consciousness, and on evaluation, he was found to have recurrent attacks of VT or VF. Now, what other clues the examiner will give me in the story to consider hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy? He may mention that this patient's left ventricle has a banana shape. Banana shaped left ventricle. That's a very, very important clue. Every question that talks about banana shaped left ventricle is talking about hypertrophic obstructive cardiomyopathy. Or on the echocardiography, this is a very, very important point. They may mention some clues. What are the clues? One of the clue on the echocardiography is that their ejection fraction will be more than 70%. Second, there will be systolic anterior motion or SAM. Now, what is this? The mitral leaflet moves anteriorly during the systole. So, we call it a systolic anterior motion or SAM. And the third echo finding is asymmetric septal hypertrophy. Asymmetric septal hypertrophy. So if any question is talking about these features, we will call it as ASH or asymmetric septal hypertrophy. So if a question is talking about this, the question is talking about hypertrophic obstructive cardiomyopathy. So just a quick recap, in hypertrophic obstructive cardiomyopathy, there is asymmetric left ventricular hypertrophy giving rise to, let us say this is left ventricle, this is aorta, this is aortic valve. So this left ventricle has assumed the banana shaped, so this is banana shaped LV. This is ASH, asymmetric septal hypertrophy. So whenever we get this, we were thinking about hypertrophic obstructive cardiomyopathy. Another important point I missed is the question may also be talking about sudden cardiac death in young individual. So the question may say that a 25-year-old, 20-year-old, 18-year-old developed sudden cardiac death. This is the most common cause for sudden cardiac death. Please remember, what important points I want you to remember is these two echo findings: systolic anterior motion and asymmetric septal hypertrophy and banana shaped left ventricle. So when you read these statements, you know the question is talking about hypertrophic cardiomyopathy or hypertrophic obstructive cardiomyopathy. And from the story, we have concluded that it is this diagnosis, and then the examiner may ask you, what is the most common cause for this condition, or what is the most common cause for death in this condition? So hypertrophic cardiomyopathy is a genetic disease due to mutation in beta myosin heavy chain gene, and it is inherited as an autosomal dominant condition. Okay. Similarly, a question may be about what we call as stress cardiomyopathy or broken heart syndrome. Now, what clues he will give? In terms of history, in a case of stress cardiomyopathy, the history clue will be that there was a sudden stressful event. Sudden stressful event like loss of some loved one or some traumatic experience the patient had. Sudden stressful event. That is one important history clue, right? Followed by that, features, patient develop features of heart failure or MI. Feature suggestive of heart failure or MI. Okay. Now, sudden stressful event followed by features of heart failure, and on examination on the echocardiography, they will mention two important points. Now, reduced ejection fraction, and the next most important thing is something called as apical ballooning. So any question that talks about apical ballooning is talking about stress cardiomyopathy or broken heart syndrome. Similarly, because of this apical ballooning, the left ventricle, so basically what happens is left ventricle, let us say this is aorta, this is my left ventricle. Now, sudden stressful event leads to catecholamine surge, and that makes this left ventricle, especially the outflow tract, contract heavily. Pressure builds up in this left ventricle. The pressure gets directed towards the apex, and the apex becomes dilated. So this dilated left ventricular apex is what we call as apical ballooning. That's why it is called as apical ballooning syndrome. And once there is apical ballooning, now this left ventricle appears the shape of the octopus trap that Japanese used to trap the octopus. So they may also mention it as octopus trap appearance of left ventricle. So any question where patient had some stressful event, followed by that he developed heart failure or MI-like presentation with sudden onset severe chest pain, and on the echocardiography they mentioned that there was apical ballooning or octopus trap appearance of the left ventricle, we're talking about stress cardiomyopathy or broken heart syndrome, and we all know that this is also known as Takotsubo cardiomyopathy. Takotsubo cardiomyopathy. Now, on the similar grounds, how will I recognize that a particular question is talking about cardiac tamponade or constrictive pericarditis? If the question is talking about cardiac tamponade, we all know that in the clinical story, what is the most common cause? The most common cause for cardiac tamponade is trauma. So they may mention that following a road traffic accident or some kind of chest trauma, patient presented with some clinical features. What clinical features he is going to present with? We call it as Beck's triad. What are the components of this Beck's triad? Beck's triad includes hypotension, raised JVP, and muffled heart sounds. So far, whatever cardiac tamponade related questions asked, invariably they have mentioned the features of Beck's triad. So any question which talks about some trauma followed by patient developing Beck's triad is talking about the cardiac tamponade. A little more details on the JVP may be mentioned. What are those findings? We will have a tall A wave on the JVP. Along with the tall A wave, we will have a steep X descent as well as we will have a steep Y descent. Sorry, in the cardiac tamponade, we will have the absent Y descent. So this absent Y descent is an important clue for the diagnosis of cardiac tamponade. So if he is not giving the full details of the Beck's triad, he may mention on the JVP there is absent Y descent. So these are the important clues for cardiac tamponade. Similarly, what are the clues that the examiner is going to give for constrictive pericarditis? How will I recognize that the question is talking about constrictive pericarditis? So if the MCQ is talking about constrictive pericarditis, what clues I will get? So there will be features similar to Beck's triad. The cause for the constrictive pericarditis is most commonly in India, it is tuberculosis. In the rest of the world, it is going to be recurrent pericarditis. So either they will mention that patient had got recurrent acute pericarditis, or he is a known case of TB, and now he has presented with features of right heart failure, that is raised JVP, ascites, hepatomegaly and all. What makes me think that this question is talking about constrictive pericarditis? They will mention an auscultation finding called as pericardial knock. Pericardial knock. So any question that talks about pericardial knock is talking about constrictive pericarditis. And another important finding is on the JVP. On the JVP in constrictive pericarditis, there will be tall A waves and steep X and Y descent. So Y descent was absent in the cardiac tamponade. In constrictive pericarditis, it will be steep or prominent. So this is the story of our constrictive pericarditis. So now from the story, we should be able to recognize which question or which disease the patient is, the story is talking about. Any patient where they have mentioned that ECG chest pain and ECG shows PR segment depression, it is about acute pericarditis. Any question where they talk about either right heart features or left heart features with raised N-terminal pro-BNP, it is talking about heart failure. Similarly, any question which is talking about alcohol, heart failure and either cardiomegaly or the left ventricular end diastolic diameter more than 6 cm is talking about the dilated cardiomyopathy. Any question which is talking about either young patient presenting with recurrent syncope, VT or VF, or patient being investigated post-mortemly for the sudden cardiac death, where these observations are made: a banana-shaped left ventricle or a systolic anterior motion of the mitral leaflet or asymmetric septal hypertrophy is talking about hypertrophic cardiomyopathy or HOCM. Any question which is talking about patient going through some stressful acute event in life followed by development of an MI-like or heart failure-like picture, and on echocardiography, the apex balloons out, what we call as apical balloon or Takotsubo octopus-like appearance, then it is talking about stress cardiomyopathy, broken heart syndrome or Takotsubo cardiomyopathy. Any question which talks about some trauma, mainly road traffic accident or cardiac surgeries, followed by patient presents with what we call as Beck's triad, muffled heart sound, raised JVP and hypotension, is talking about cardiac tamponade. One extra feature or detail to pay attention is absent Y descent on the JVP. And if the question is talking about similar features but not trauma, but rather in a patient with tuberculosis or recurrent pericarditis with right heart failure features like raised JVP, hypotension, but instead of muffled heart sound, the question will be talking about what we call as pericardial knock. It is talking about constrictive pericarditis. And one key feature of this is that unlike the cardiac tamponade where we have absent Y descent, here we will have a prominent or steep Y descent, right? So this is the story of our CVS patients, cardiovascular questions, how the story evolves, and from the story how we can pick up the diagnosis. Similarly, we will do that exercise for few neuro cases as well. Now in neurology, a lot of clinically oriented myasthenia gravis questions come. So how will I recognize that the story is of myasthenia gravis? Myasthenia gravis, being an autoimmune disorder, is typically more common in females than males. So most of the questions are talking about females, and being an autoimmune disease, and that too if it is talking about females, it is mostly going to be middle-aged. Or if it is talking about male, then it is mostly going to be an elderly male. Now what symptom they present clinical feature wise, that was about demography. In terms of clinical features, myasthenia gravis patients generally present with ptosis plus proximal muscle weakness or proximal myopathy. Now what clues the examiner will add in the story? They will mention that these symptoms, the ptosis, proximal myopathy, they are associated with diurnal variation, or they would call it as fatigable weakness. Diurnal variation or fatigable weakness. Which is a very, very important clue towards myasthenia gravis. Now, a similar neuromuscular junction disorder is Lambert-Eaton syndrome. What clues examiner will give? Lambert-Eaton syndrome is a cancer-related condition. So there may be history of some cancer being present, mainly the lung cancer. And then the second thing they will mention is that here also patient will have weakness which has diurnal variation or fatigable, which shows diurnal variation. Many questions are asked to differentiate between Lambert-Eaton and the myasthenia gravis. So in Lambert-Eaton, that diurnal variation that we get, the weakness is more in the evening. Weakness is more by the end of the day. And in case of Lambert-Eaton syndrome, weakness is maximum at the beginning of the day or in the morning. So from the story, if the weakness progresses with the progression of the day, it is talking about myasthenia gravis. If weakness decreases as the day progresses, it is talking about Lambert-Eaton. Now in investigations, what clue they will give? In the investigation, in myasthenia gravis, if I do repetitive nerve stimulation study or single fiber electromyography, it will show decremental response. Means the more and more I go on stimulating the muscle, the compound muscle action potential goes on dropping. But in case of the Lambert-Eaton syndrome, the same investigation will show an incremental response. In the Lambert-Eaton syndrome, if I keep giving an electrical stimulus to the muscle repeatedly, then the strength of contraction goes on increasing, or in other words, the compound muscle action potential goes on increasing. So we'll call it as incremental response. Incremental response. So every time you have to differentiate between the myasthenia gravis and Lambert-Eaton, please pay attention to 3 points. In the demography, if it is talking about a middle-aged female, it is mostly pointing towards myasthenia gravis. If it is talking about some patient with lung cancer, of course, middle-aged or elderly, with male mainly with history of smoking and then lung cancer, it is pointing towards Lambert-Eaton. Second, they may mention the diurnal variation in the weakness. If the weakness increases with the day, then it is myasthenia gravis. If it is decreasing with the day, then it is Lambert-Eaton. Third one is, of course, the investigation, the SFEMG or single fiber electromyography. If it shows decremental response, it is myasthenia gravis, and if it shows incremental response, it is going to be Lambert-Eaton. Okay. Now, similarly, there may be a question on JB syndrome, and you should be able to recognize that this story is about JB syndrome. So how will I recognize that the story is of JB syndrome? First thing that they will mention in the JB syndrome case is that a predating infection. So before patient develops the symptoms of JB syndrome, they may mention that there was an infection, mainly the gastroenteritis. And the question may go on to mention that it was caused by Campylobacter jejuni or some other cause, including vaccine, right? Predating infections or even vaccine may be mentioned. That patient has received vaccine, after that he developed these symptoms. What symptoms the question will talk about? It will talk about ascending paralysis, paralysis starting in the feet and then progressing upwards. It will talk about ascending paralysis. In the examination, this being a disease of the lower motor neurons, JB syndrome is a disease of lower motor neuron. The question will talk about when lower motor neuron damages, muscle tone decreases. So there will be talk about flaccidity and areflexia, decrease or absent reflexes. So any question which talks about someone developing ascending paralysis following a GIT infection or a respiratory infection or vaccination, where he is presenting with ascending paralysis and examination shows absent reflexes and decreased muscle tone, is talking about JB syndrome, right? Now, similarly, there may be question on what we call as amyotrophic lateral sclerosis, ALS or amyotrophic lateral sclerosis, which is a motor neuron disease. Motor neuron disease. So how will I recognize that this story that I'm reading is talking about amyotrophic lateral sclerosis? So pointers generally mentioned in these ALS patients is the first one, that it is typically affecting elderly patients. Typically elderly patients. They present with what? Clinically they present with progressive limb weakness. So they say that patients' limbs are becoming weak progressively, plus they will present with what we call as pseudobulbar or bulbar palsy. Pseudobulbar or bulbar palsy. Now, what are the signs of this pseudobulbar or bulbar palsy? What are the signs of pseudobulbar or bulbar palsy? So please remember, any question where patient has got pseudobulbar or bulbar palsy, they present with three features. We will call them as the 3Ds of bulbar or pseudobulbar palsy. The first D is dysphonia, difficulty to produce voice. Second one, difficulty in articulating the words. We will call it as dysarthria. Dysarthria. And the third one, difficulty to swallow food. We will call it as dysphagia. So any question which talks about someone having progressive weakness of the limbs and then the 3Ds, dysphonia, dysarthria, dysphagia, may be a pointer towards amyotrophic lateral sclerosis. And the third, the most important clue, is that this patient will have findings suggestive of UMN and element damage. Any question, see, there are conditions where you can have UMN and element damage, but for all practical purpose, if it is a NEET PG or an FMGE exam, any question which talks about UMN and element damage findings in a single patient is always talking about amyotrophic lateral sclerosis, right? Now, similarly, if there is a question on tension type of headache, how the examiner will build the story. If the question is on tension type of headache, it will always talk about a middle-aged female. It's going to talk about a middle-aged female. Second thing, the history clue. What clue examiner will give? The patient generally describes the headache as band-like sensation, or a vice-like grip. Okay, and the third thing that examiner will mention, that these headaches are bilateral. So middle-aged female having bilateral headaches, which she describes as band-like sensation or vice-like grip, is talking about tension type of headache. Right? If the question is about migraine, again it is going to talk about mostly a middle-aged female, where the clue, instead of band-like sensation or vice-like grip, they will mention that patient has got photophobia, phonophobia, intolerance towards bright light, photophobia, phonophobia, and loud noises. And the question may be talking about presence or absence of aura. And the question will also mention that the headache is unilateral. So any question which talks about a middle-aged female presenting with headaches which are associated with photophobia, phonophobia, aura, and unilateral in nature is mostly talking about migraine. So key differentiators are the statements. So if the statement says band-like sensation or vice-like grip, it's about the tension type, right? If it is talking about aura or a photophobia, phonophobia, even nausea, vomiting, is pointing towards migraine. Similarly, if I have to build a story on the cluster headache, what pointers I will add in the story of the cluster headache? So if it is about cluster headache, how is it different from migraine? So if the story is about cluster headache, instead of female, this may mention a middle-aged male, because cluster headache is more common in males than females. It is more common in males than females. Second, Just like how I'm giving you a clue that if I'm talking about band-like or voice-like, think about tension type. And if I'm talking about photophobia, phonophobia, aura, think about migraine. Similarly, if I mention that the headache is seasonal or alcohol as a trigger, alcohol triggers the headache, right? And if I'm talking about, the question is talking about red eyes or facial flushing or nose block, it is again all pointed towards cluster headache. So this is how we recognize the pattern in the question to know that, sir, this question is talking about migraine. Now they may be asking anything about it. Like for example, the story may build like this: a middle-aged female presented with recurrent attacks of headaches, and the headaches are unilateral. They are associated with some kind of aura and photophobia, phonophobia. Now you know that it is talking about migraine. Now they will ask you, what is the drug of choice for acute treatment of this patient's condition? So only when you can decipher the story and know that this is talking about migraine, you will be able to answer. Now you know that the drug of choice for acute treatment of migraine is triptans. They may be asking you, what is the drug of choice for the preventive treatment of this patient's condition? Now that you know that it is migraine, the drug of choice is going to be propranolol. So that is the importance of understanding and deciphering the clinical stories. So now from today onwards, till you deal with your exam, make sure that for every system you have in mind some stories. Like for example, I gave you the examples for neuro and cardio, right? Like all the major common diseases from which clinically oriented question come from neuro and cardio, we learned the key pointers. Take a little time when you study other systems and keep one separate page. You just need one page, because in 4 or 5 slides I made the key pointers listed down for 2 major systems, right? So you can do that for remaining systems as well. So keep one page where you write the key pointers. Many of them are the clues for the diagnosis, right? If this statement appears, examiner is talking about this disease only. Like as I gave you an example of worst headache of my lifetime. Whenever it appeared in the MCQ, it is talking about the subarachnoid hemorrhage. If the question says there is a malar rash which is photosensitive, worsens on exposure to light, it is talking about SLE, right? Similarly, whenever a question says banana shaped left ventricle, it is talking about the hypertrophic obstructive cardiomyopathy. Whenever a question says that there is apical ballooning, it is talking about stress cardiomyopathy. Whenever a question says that there is backstride, it is talking about cardiac tamponade. Whenever a question says there is pericardial knock, it is talking about constrictive pericarditis. If a question says that there is weakness which has a diurnal variation with progression as the day progresses, it is myasthenia gravis. If a question talks about the ascending paralysis following an infection and flaccidity areflexia, it is GB syndrome. If a question talks about one patient having both UMN and LMN findings, for all practical purpose, it is ALS, right? So if there is a question on headache with statements like band-like sensation or voice-like grip, it is tension type. Similarly, if it is photophobia, phonophobia, and aura, it is migraine. Alcohol having occurring in the same season, mainly male, with some redness of the face, eyes, it is talking about cluster. So make 1 or 2 pages for every system and write down the way I have written. That will compile all your key points that you need to know for the solving clinically oriented MCQs. And it makes it a breeze in your final NEET PG exam, where it's like you can quickly recognize the examiner's mind, what he's thinking about while framing the question. Examiners throw these statements just like that. So no clinically oriented question is very, very complex. They are simple. Examiners are putting out these clues only, but unfortunately we overlook these clues when we are reading the theory, because we are so much fixated on knowing those so-called what is the drug of choice, what is the investigation of choice, what is the most common cause for death, what is the prognosis, what is the prevalence, more common in males or more common in females. We are fixated on these one-liner points and we ignore the examiner clues, right? So get a page for every system. In 1 page or 2 pages, you should be able to compile the stories of every disease that that particular system covers. If you want me to do that and share, I'll definitely do that and share on the Telegram in the PDF. But I've given you just how you learn to recognize the story, and from the story make a mental diagnosis, so that whatever is the final one-liner attached to that story, you should be able to answer. That's it from me today. This was mainly to give you a gist how to deal with clinically oriented questions. But if there are any bothersome topics which you are not able to understand or you're finding it difficult, let me know. I will try to cover that through the Telegram soon. Okay, so if there are no queries coming up, I'll call it a day. I'll see you in the next class. Till then, have a good time. See you soon, guys. Bye bye. Study well and